Okay, so welcome everyone. I hope you all enjoyed our morning session. We are here today to kick off our afternoon session. And I also hope you guys enjoyed looking at the Flipgrids. And if you didn't have time to look at them over the lunch break, they'll be available and we'll pass those links along to you after the conference as well. So you can go in and look at them if you would like. So today we have a great session planned on adverse childhood experiences and early prevention. I'm Jen Leiferman, the director of the Rocky Mountain Prevention Research Center, and I'll be moderating this session. We have four speakers: Dr. Hy Fitzgerald, distinguished professor from Michigan State University; Dr. Steve Berkowitz, Department of Psychiatry here at Anschutz Medical Campus; myself, and Dr. David Olds, Department of Pediatrics here at Anschutz Medical Campus. Each speaker will have 12 minutes to present their work. If we have time for a question after each presentation, we'll do so. Otherwise, if we're running a little short on time, we're going to hold all questions to the very end. We've slated a good 15 to 20 minutes at the end to have a great discussion. So as the presentations unfold, please feel free to submit your questions by Q&A, and I'll keep a lookout for those. And if we can get them answered in between presentations, we will, and then the bulk of them we'll answer at the end of all four presentations. So, and we'll just go first. Hy, you'll present, and then we'll move to Steve, and you can share your screen, Steve, after Hy finishes, myself, and then David, and then we'll wrap up with our Q&A. If you have any technology issues or anything along those lines, Stephanie Baker is on the call here and you can direct message her. So with that, Hy, take it away.
Well, thank you. This is the group. It's multiple universities at Western Australia. And I just want to acknowledge I would do this. I was there, but I will. The Aboriginal and Torres Strait Islander people where these universities reside. So next slide. So these are us. Ben Pretis is the head of the project. Rochelle Matats designed some of the intervention programs. And Daniel Colley's an economist, epidemiology economist who works with us on this project. Next. We're going to whip through a lot of slides in 12 minutes. I just want to give you an idea of what we are attempting to do in Western Australia, because I think it's very, very similar to STANCE. So there are all kinds of ACEs. Everybody knows the Felitti et al. 1999, but people have been studying adverse childhood experiences long before they did their epidemiological study. Michael Rutter had a list of risk factors, Arnie Samaroff, through his studies of schizophrenia and other people. So what I did was go across all those different versions of ACEs and sort of put them into three categories. And the numbers here reflect which publication. And there's a whole bunch of publications at the end, because I think everybody gets these. If you don't, just email me and I'll get the whole thing to you. So these are much more diverse than just the Felitti. And underlying all these, but never listed in lists of ACEs, are the neurobiological consequences of all this stuff, including the genetic and epigenetic things that begin to happen to us as we begin our experience as a zygote. So next. Ooh, these are slow. And then down the street at the University of Denver, Angela Narajan has a set of positive things that can happen to you. We focus so much on psychopathology, at least in my life, that we got to remember there are a lot of things that are really nice that happen to people. And then Jennifer Hayes Grudo and Amanda Morris also have another way of assessing positive aspects of early childhood experiences. Go ahead. All the work that we do is driven at Michigan State University, is designed, and the work we did in Western Australia from a developmental relations systems perspective, because I believe that individual family treatment, although it's essential, it solves maybe one person at a time or one die at a time, but there are 7 billion 600 million of us on the planet. So we need more systems approaches to change the surrounding networks that support individuals and families in development. Next. So we focus on the emotional mental health issues primarily in this work. And it's related to work that I've been doing for a long time in infant mental health. So next. This is an example of the kinds of models that guide our work, all the kinds of external factors that can influence a family, and then the family relationships, whatever the family might look like. You can modify this thing to make a composite of any kind of family that you want. This happens to be sort of the traditional nuclear family. Next. Everything is from a lifespan developmental perspective with a heavy emphasis on organizational processes at certain periods of development, and then the transitional phases over the lifespan into adulthood. Everything we're going to talk about today focuses on that first, I'm using my pointer here and I don't even have, it's not showing up in your screen, is the bottom one there, starting with the prenatal to about age 4. Next. So we did our work in 2 different cities that are part of Perth. Next. Joondalup and Wanneroo. Joondalup's 154,000 people, Wanneroo around 187,000. What we looked at were the ages of the kids who were 0 to 4, our target population in the community. We collected as much data as we could possibly collect, so that as this project goes along prospectively, we'll be able to analyze data and begin to and also shape data as it relates to changes in the community and the ecological context within which these families live. You can see they're pretty good immigrant populations in each of these cities. These are each about 16 kilometers north of Perth itself. Next. And this gives you an idea of the size of the cities. There are about 340 square miles of them, but you've got 8,293 square miles in the Stance project. So you're a much bigger territory that you're going to have an intervention in, but this is still a pretty sizable population. And as you can see, there's one hospital that services this entire area. Next. So Perth is, Australia is organized, as you might suspect, the way England is organized. So the city of Joondalup actually has 14 cities, and the city of Wanneroo has 14 cities. And these are other cities. They have their own governments and everything else, but they're collectively called Joondalup and Wanneroo, and Perth considers Joondalup and Wanneroo as a part of Perth too. So just to give you a sense that of the complexities, governmental complexities that we had to connect in order to pull this thing off. Next. So the first thing we want to know, where are the various segments of the Western Australia system of care located in these 2 cities? Next. So we GIS mapped everything. Here's the government health and mental health services. That's one of the first services, and you can see where the hospital is located. It's actually in the actual city of Joondalup. If you take the top part of that map of Joondalup and stick it way at the bottom right of Wanneroo, that's how they're connected. Next. Then we wanted to know where all the early childhood education care, community services, and libraries are located, because libraries are important, because libraries throughout this region, and there are a lot of them, each little town has a little library, do literacy programs starting with toddlers. Next. Then where are the universal services located? And take a look at on the right-hand side one, the one is called Two Rocks. Keep that in mind because you're going to see it later in a social network analysis, and you understand it better when you see it as a little dot. So next. Then where are all the general practitioners? And these are not mapped, they're just there in terms of number of general practitioners per thousand of population where 0 to 4-year-old families live. And if you look down at the Tapping Ashbury Sinagra on the right-hand side, you'll see there are none. And then there are a lot on the Joondalup Edgewater blue map on the left. There are 10.7 general practitioners per thousand of 0 to 4 age kids. So they're distributed differently based on the population of where the 0 to 4 age kids live. Next. We then went to all these agencies, and next slide, went to all these agencies to find get a better sense of how they function and what are the problems they have to deal with. So one of the things we asked about were barriers. And the biggest barrier was staff turnover, and you're going to see in a slide shortly what age, in terms of experience, that turnover occurs in. Lack of resources, the political landscape, these are the major sort of barriers. Next. Here's the 0 to 4, 22.3%. That's the age group where most of the turnover occurs. And so you see the least experienced workers in the field are the ones that are moving around the most as well. So that's a continual flow of people into 0 to 4. Much more stability the more years in the working at the agency. And then this is the proportion of people, the percentage of the people that got involved with our project from the community, from the health system, the mental health system, the primary health care system, and education. Next. The expected benefits, we asked people working in these agencies, what would you get out of having a greater cohesion of services across the system of care? And so they said, oh, all these great things. So they know, but they would get better health outcomes, maybe. They would understand mental health issues more, and you have more interagency connections. The question is, knowing it and practicing it are two different things. Next. We had a lot of training. That seemed to be okay, and they had access to that. Next. Well, this is going fast. The intervention programs were based, keep going, Steph. The intervention programs are based on materials developed the Michigan Association for Infant Mental Health. Go ahead. And they were put together by Rochelle Matats, pre-tested in Ireland about 6 years ago, and then modified for here. There's a lot of attention to the social relationships of babies during the first 2 years. Next. We focused on critical periods and organizational periods during infancy, and then mostly the social, emotional, and cognitive, behavioral, and regulatory processes that occur. Next. And then there's very specific trainings related to social emotional relationships of mothers, babies, fathers, babies, mothers and fathers, when they're at the agency, and what the critical signs people can look for that might suggest problems in their relationships. Next. We ran a lot of focus groups. Where do you get information with parents? Where do you get information about early development? Most of them get them from the agency. A lot of them get them from family and friends, and then a lot from the internet, which is a bit of a concern. Next. Where do you, where your first, which agency provides you go to for your first contact? Most of them go to general practitioners. So we really want to focus on that group. Next. Most people have no difficulty getting to any kind of service because they have a great train system, a great bus system. Next, so that was not a problem, not perceived to be a problem. Relatively little interagency communication in a system of care. Desire for a lot more information about 0 to 3, so we can provide that. Next. And then we would hold, throughout this whole process, lots of focus groups with various people from the agencies, various people from the community to get their input to the things that we were learning and developing. Next. We're almost done. Go ahead. So we did a social network analysis to try to find out more information about the extent to which these 6 components of the system care actually interact with each other. Next. And these are the agencies and the percentage of people from those agencies who were participating. Go ahead. So this gives you a sense of what the kind of data are that you look at in a social networks analysis. Go ahead. So the agencies have 1,684 partners across these 2 cities, and all the little spots that you saw in the GIS mapping. Training needs, educational program, and developing new initiatives are important. We asked them, how do you develop relationships with other people in the system? Well, it was mostly through, well, I know Joe, or and I know Sam, or whatever, or Jane. Connecting with others, participating in committees, but little attention, as you see at the bottom, is given to anything related to outcomes. Go ahead. What aspects of collaboration contribute to success? Boy, they know them all. Go ahead. So you're going to see they don't practice very many of them. Perceived barriers to the primary, the system of care for prenatal to infant mental health. Lack of time, staff turnover. You probably can make, many of you in your agencies, if you're in agencies, can make this same list. Go ahead. So what are the keys to making referrals across a system as complex as exists in Western Australia and in these 2 cities is the degree to which you trust another organization. And you can see the level of trust here is not great. All the community red circles are mostly collaborating with each other. Most of the education purple circles or agencies are collaborating, etc. So you would want to see a much bigger mix of colors in this thing. Go ahead. So the level of trust between agencies was very low, which means very few referrals. The degree of valuing other agencies was low. In all of our focus groups and training programs, we could never get general practitioners to come to any meetings other than those just for general practitioners. So we know we have to work on that particular group because that's the group that is the #1 contact for primary care, first contact that most people have. So the system interconnectivity was very modest, to say the least. Go ahead. So we need to enhance levels of trust and value within the system, build stronger connections and integration among the agencies, build more positive relationships, person-to-person relationships across the agencies, and find ways to do that. We're considering using the Early Childhood Service Intensity Instrument that's used in Minnesota and a lot of other places in the States, because it assesses systemic outcomes of early childhood services and provides annual feedback about that. Much more participatory action research elements have to be built in the system. For that little place that was way up there all by itself, we really need telemedicine to be able to help them, because it's quite a distance, and there's no other services available for people in that entire city within the city. And then build stronger principles of mental health in all segments of the healthcare system. That's it.
Okay, thank you. Hi, I appreciate that. For time, we're going to go ahead.
I have to show you the next one. You have to show the next one. Okay, that's the acknowledgement to all the federal funding and et cetera. That's it. It's done.
Okay. Thanks, Hai, for your great presentation. I think for time, we're going to go ahead and move on to Dr. Berkowitz. Steve, are you planning to share your screen?
Yep.
Okay, thank you.
Well, good afternoon, everyone. What I'm going to talk about, is really what I would consider secondary prevention as an intervention, and identifying and intervening with children and family who have lots of risk factors. And as Hiram said, we've been studying child adversity and adverse events for a long time. But I do think one of the key things when we think about population health and public health is to think about a continuum of interventions and care, from primary through even quaternary interventions. I'm mentioning this is my one disclosure related to the study. We are in Philadelphia evaluating this treatment, the child and family traumatic stress intervention, for youth who have been assaulted and brought to the emergency department. And that's an R01 that's currently going on. I don't need to share the slide for all of you, but just a reminder of the just ubiquity of violence exposure for children and youth across the United States. And so while I'm a major proponent of universal and public health interventions, I also recognize that that's just not sufficient. The kids, I'm having volume issues, sorry. Let me know if that's better, folks. No, I'll try to take it off. Anyway, as I was saying, despite primary and interventions, okay, I guess you can hear me now. Children and youth are still exposed, and intervening and identifying these children families at high risk is a key part of that public health, population health continuum of care. So if we're talking about early interventions, this with the idea of preventing post-traumatic stress disorder in children, the goal here should be on enhancing protective factors in the peri-traumatic period after an event. We know that social and familial support are crucial. We know that processing the experience is crucial. And we know that the sense of coping efficacy are also crucial to best outcomes. Importantly, that's not sufficient. And why this intervention falls clearly into the prevention of ACEs model is that good evaluation and identifying the needs of the child and family beyond the peri-traumatic period is also a crucial piece of an intervention that's post-event. This is just the paper of our RCT. So what do we try to do? We try to enhance family and social support. And we do this by improving communication about symptoms, reactions, the experience of the child, and their caregiver. So the goal here is not necessarily to focus on the details of the event, but to understand the child's experience, for the caregiver to understand it, with the goal that the caregiver can provide more emotional and psychological support. And then we also, of course, teach coping skills, certain intervention models that they can practice at home. One of the things that I'm going to keep harking on is the idea that we want to create, or we are creating, opportunity out of crisis. So it's more than just an intervention to prevent PTSD. It's also identifying children and family who are at risk. And this is an opportunity because they understand that if bad things occur, they know something is wrong, it's environmental, and it's a window of opportunity to intervene with families that often have fallen through the cracks. In brief, the model is 5 to 8 sessions. We divide it by initially having a meeting with the caregiver. We use scales to identify symptoms that the caregiver tells us about for themselves, for their child. And then we also address needed case management and care coordination issues. The meeting with the child is almost identical to the meeting with the caregiver, where they fill out the same scales about their own symptoms. The third session, which I really see as the center point and focus of the intervention, we compare the caregiver and the child's reports about the trauma symptoms on these scales, and then we discuss them and help them come to some agreement about what is going on. And this is the opportunity to really hear from the child how they're feeling, for the parent to respond about their responses, and leads to the ability to start support and understand one another more effectively. And then we identify no more than 2 specific concerns, trauma reactions, and we provide interventions that they can practice with us and also at home. The fourth meeting is together, where we really praise and support the communication attempts. The measures are re-administered together. And again, this is an opportunity for discussion of assessing the level of distress, maybe doing some mid-course corrections and practicing coping skills. And then the 5th session traditionally is a similar format, session 4, I shouldn't say 5. And then also identifying what more they need and how they may need it. We also often will add some sessions to deal with disputes, longstanding controversies, parental symptomatology with maybe traumatic stress or maybe others. So we ran a randomized controlled trial, basically versus a supportive psychoeducational session. The mean age was 12 in both groups, very lucky. Recruitment was from a sexual abuse program, a pediatric emergency department, and that time I was at Yale at the New Haven Department of Police Service. We reduced PTSD at 3 months compared to the control group by 65%. And we also reduced anxiety symptoms at that time period as well. This is just a graphic of the findings. This is also interesting. Back in the partial PTSD days, we had even greater effect. I want to also mention we just did a study where we demonstrated that the intervention also decreases post-traumatic symptoms in parents. And we know that that's crucial because there's a high correlation between PTSD in parents and PTSD in their children after such an event. So in summary, we need a continuum of care from primary to quaternary, tertiary prevention. We think family approaches are most effective, I think, as everybody else here does. And we also need to do more. We also have to identify children at risk and at high risk of ACEs. Thank you.
Okay, thanks, Steve. That great presentation. If you have questions for Steve or for Hai, just go ahead and put them in the chat box there. And then once our last two presenters are finished, we'll have a question and answer period. So Stephanie, would you mind sharing the slides? Okay, thank you. Okay, so I'm going to go ahead and talk about a project that we have with the Rocky Mountain Prevention Research Center. It's called STANCE, Leaking Systems to Address ACEs in Childhood Early On. Next, please. And before I get started, I just wanted to thank our investigative team. And so Dr. Jenny Puma and I are the co-PIs. Dr. Betsy Risendahl, Glenn Mays, Beth McManus, and Danielle Varda are all co-Is for this project. And then we have a fantastic team on the ground, David LaRocca, Marlena Martinez, and Angela Haney here in Denver, as well as in the San Luis Valley. So next slide, please. So the Rocky Mountain Prevention Research Center is one of 26 funded prevention research centers by the CDC. All prevention research centers are doing prevention work and have to have a strong community engagement focus. And so this work that you'll hear about today, we've worked closely with our community partners in the San Luis Valley, and I'll share a little bit more about the San Luis Valley in an upcoming slide. But one of the things we did is we had a community advisory board and down in the San Luis Valley, and they spent a year discussing where should the community move and what are the primary needs that they would like to address. And they came to the conclusion that they wanted to work on ACEs. So these prevention research centers all have community advisory boards, all work with community partners and typically in a designated geographic community. And the San Luis Valley is our partner. And given the need to address ACEs in the Valley, the Rocky Mountain Prevention Research Center partnered with folks in the San Luis Valley to develop the 5-year project that you'll hear about today. So why ACEs in the Valley? Well, we know that ACEs, adverse childhood experiences, have a profound effect on the child's developing brain and body and lasting impact on the person's health throughout the lifespan. There are 10 recognized ACEs, which really fall into 3 types: abuse, neglect, and household dysfunction, which you've heard from our first 2 presenters. And if you are exposed to ACEs, you have an increased risk for such things as alcoholism, drug abuse, depression, suicide attempts, and numerous chronic health conditions. So there's definitely a high risk for morbidity with exposure to ACEs. And in the Valley, there's a higher prevalence of ACEs as well. Next slide, please. So this is a picture of not all of our community advisory board members, but most. And many of these individuals pictured here have been working with the RMPRC in partnership for even close to 2 decades. Next, please. So what is the 5-year project? Well, we wanted to, the Community Advisory Board and the community of San Luis Valley wanted to work on a way to prevent ACEs. So that's a big thing that we had to tackle, and we came upon an idea to have a program that's multi-level intervention within a systems framework. And the ultimate goals of our 5-year project are to build a community awareness of ACEs, increase the identification of children and families who are experiencing ACEs, increase the use of evidence-based intervention strategies in early child education settings, and then improve those linkages of care for the families to the appropriate social support services. So I'm going to break this down, and then I'm going to share a little bit of preliminary results that we have. So the next slide shows a picture here that kind of helps break down what is kind of a convoluted project. So the first thing we're going to do is the universal screening. And the Valley suggested that we will work with early child education settings. So the stance framework is really set up to be moved from community to community and come to life with however the community feels like it's the best way to move forward. And in moving forward, we want to leverage extant resources. So the San Luis Valley identified a great infrastructure around early child education settings. And so we are using the early child education settings as a hub for our project. So the first step is we're going to do screening in the early child education centers to identify those young kiddos and families who are at risk for having exposure to ACEs, and then hopefully provide better linkages to care to services in the community. The second step is really primary prevention, and it's aimed at working with teachers and parents to promote social emotional development and competence in kids in hopes that we can prevent any of the adverse effects of exposure to ACEs. And the last is to really work with the community and strengthen those resources for our families in need. So I'd like to just take a couple minutes and break down each of these sections. So Stephanie, go ahead and next slide, please. So the universal screening. So we are in our second year of the project, and we are just about ready to start this. We piloted in another community, and we're now moving into the San Luis Valley. And we'll be working with our early child education settings to conduct a screening for our kiddos and families. And we'll be looking for ACEs and trying to identify families with high ACEs. But we're also going to be surveying the BACEs, the benevolent childhood experiences that Hai shared earlier, as well as indicators on depression, anxiety, and more protective factors around resiliency and mindfulness. And the goal here is to do this screening in a strength-based way so that we identify families who are having some needs, but also help them identify their strengths and really work on enhancing those strengths. The next slide, please. The second tier is again going back to that early child education setting, and we're going to go in with the teachers and help them by providing training to deliver a program called the Pyramid Program. And we'll also be working with our families and doing workshops on positive solutions. And those will just strengthen the supportive environments in the school setting and at home in the families to really develop nurturing and responsive relationships. And then for our kiddos who need more intensive intervention, that also will be available. Next slide. And last, we're going to work on that systems of care. So as we identify these families at risk in the ECEs, we want to make sure we can link them to appropriate care in the community. So we've worked with Visible Network Labs, Danielle Vardas, a co-investigator, and her team, and they have helped us do an assessment using the partner tool, which helped us look at the Valley to see what organizations are there currently that are supporting our families who are at risk, and what does the communication look like, and what are our next steps in helping the community if we have identified some opportunities for growth. So next slide. So for baseline data, just right after the pandemic started, we got in the field and we conducted this partner tool with our community partners in the Valley. Next, please. And we were really happy with this. Response rate is 75%. Again, given we're in the pandemic and there's a lot of stress on the infrastructure, especially public health infrastructure in small rural areas such as the Valley. And the Valley has a primarily Hispanic population. The poverty rate's 20 to 25%. And like Hai said, it's about the size of the state of Connecticut, if that helps put in perspective. And it's in the southwest part of Colorado. So there you can see the counties that represent the San Luis Valley. Next slide, please. So this partner tool helped us see what are all the organizations serving our families at need. This is a social network map. The circles are the nodes, which in this case represent the organizations. And then those lines in between represent any kind of pathway or partnership going between the organizations. So you can see the legend to the right. And for example, the yellow balls, those would be partner organizations that serve all 6 counties in the San Luis Valley. And then you can see the rest are color coded. So what we really want to see is a lot of relationships going back and forth and connectivity across these organizations. Next slide, please. So our baseline survey had some really interesting results. So part of our job for our 5-year project is to build awareness around ACEs and help our organizations connect with one another and offer strong systems of care to support our families. So one of our first questions is, what is your awareness of ACEs? And for the most part, our partner organizations knew what ACEs were, with 45% being very aware, and then there's some work to do with the others percentages. Next slide, please. The next question, what are the outcomes of community relationships? So how are those relationships happening with our partners? And we can see that one of the main things, how people are leveraging their partnerships, the exchange of resources and information. What we'd like to see with this 5-year project is that more people report an improved screening, referral, follow-up process. So some of those that are down lower on how often they were reported for this baseline survey. Next slide, please. How successful is the community addressing ACEs? So what do the partner organizations say around this? You can see in the green and the blue, that's somewhat successful to very successful. And then to the left is where we need work to do. So we have some room for growth here where we really want to help these partnerships. And you can see that down at the bottom there, identifying barriers and discrepancies between systems level and person networks of care is a place that they need work, and you'll see it later where they really want more work and effort done in this area. Next slide, please. These are our common barriers, financial resources, and poor communication, lack of trust with the referral process, and you can see the others down there, but we really want to focus on the poor communication and lack of trust with the referral process. Next slide. COVID's effect. COVID has had some effect on what they're providing for their services, but better than we thought. So that's hopeful. But there is some room there where certain partners are saying that we may not be able to offer the same amount of services right now. Next slide. So where to go forward? Which priority is most important? So improving linkages of children and family support services is where the partners are focusing. And STANCE is really trying to address that issue over the next 5 years and identifying the barriers and discrepancies between systems level and personal networks of care. Next slide, please. So next steps. We're going to continue to do this assessment and work on better understanding the quality and quantity and outcomes of these partnerships, identify opportunities for growth, continue to invest in relationships. So one of the things we're doing is we're working with partnerships that are already going on in the San Luis Valley. So that you can think of like coalitions that are already there, efforts that have already been mobilized that we can just leverage and build on. And we've had great participation and interest in how to do this. And so that the organizations are starting to come together to think about how they can strengthen those linkages across organizations to better support our families. And the last thing I want to say, we're in the field, we're starting to implement STANCE. We'll be identifying those families, and those families who are at highest risk, they will actually be given a person-centered app that they'll take. And the app actually helps them identify those partner organizations in their community and hopes to really strengthen that referral process out to those support services. So in closing, we really want to strengthen the network of care in the community, and we want to strengthen the network of care from the family to the community. Next slide. So I'd like to thank Visible Network Lab for the great slides that they shared on the social networking process. And we'll hold questions till the end. And our last slide, this is just how you can get in touch with the Rocky Mountain Prevention Research Center if you want to learn more about our STANCE project. With that, I'll pass along to David.
Hi, everyone. I'm going to share my screen, and let's make sure I can get this baby going here. Okay. Can you all see this?
No, we can't see it.
Is the answer no?
No, cannot see it.
Okay, so let me see what I can do to make this work properly. I'm going to use my time to talk about how nurses in nurse-family partnership address adverse childhood experiences in the conduct of the program. And I want to mention that you don't have the slide because I added it just a while ago on disclosures. I need to make two disclosures. One of them is that the university and I own the intellectual property for Nurse Family Partnership. And in the US, we make the intellectual property available to a nonprofit that uses this to expand and serve families in the US. And we do this in a way that's royalty free. The nonprofit, the Nurse Family Partnership National Service Office, gives our center at the university a contract to conduct research to improve nurse family partnership and its implementation. And then in addition to this, we're working with 7 other countries around the world. We charge them royalties and consultation fees, and all of that money that comes back to our center is used to support, again, research on improving the program and its implementation. None of that money goes to me personally. Okay, Stephanie, let's try the next slide. Thank you. I just want to take a moment to talk about Nurse Family Partnership. It's a program of prenatal and infant and toddler home visiting by nurses that focuses on low-income mothers who have had no previous live births. And the program has achieved replicated effects across trials with different populations and living in different contexts. And I think that one of the reasons it's been successful in those respects is that we've spent the last 4 decades trying to be clear about what nurses are actually trying to accomplish, what the intermediate behavioral objectives are in accomplishing those goals, and what are the methods that nurses use to produce these effects. And in all of this, I would say that it's one thing for us to have a program that's brought in from the outside, but I think it's critical that the program, we think, activates and leverages parents' instinctual drives to protect their children. This is critical, we think. And the other piece in this that I think is critical is that the nurses work in strengths-based ways with families rather than highlighting all of the challenges that families have. Next one, Stephanie, please. The 3 specific goals are to improve the outcomes of pregnancy by helping women improve their prenatal health. The second is to help parents improve their children's health and development by helping parents provide sensitive, responsive, competent, effective care for their young child. And the third is to help parents improve their own health and their economic self-sufficiency by starting to imagine what life might be like for themselves and for their children, to make wise choices about what needs to be addressed to protect their own health and their children's health and development. And they focus a lot of time on helping women imagine they're completing their educations and finding work, and critically, the role that the timing of subsequent pregnancies will play in helping them accomplish what's important to them. Now, the other piece on this is that nurses systematically involve grandmothers and fathers and other concerned members of the informal social network and link families with needed health and human services in the community. Next slide, Stephanie. The program is founded on 3 theories, that is attachment theory, human ecology theory, self-efficacy theory, and the specific modifiable behavioral objectives for the program are grounded in developmental epidemiology. Next slide, please. We've tested the program in 3 randomized clinical trials here in the US over the last 4 decades. First, with a sample of low-income whites living in a semi-rural community in upstate New York, Elmira, New York. And many people, when we first published the results of the Elmira trial, said, gee, you've got a program that works, you need to make it more widely available. Well, we took the position that we ought not to do that. We felt that we needed to know whether the program might produce corresponding effects in a major urban area with a primarily African-American sample. So we replicated this study in Memphis, Tennessee, beginning in 1987. And people said to us when we started publishing the results of the Elmira and Memphis trials together, people said, well, that's good, but you could be even better. You could produce even more effects if you were to deliver this program with paraprofessional visitors, people hired from the community. So we conducted a 3rd trial in Denver that systematically compared the relative impact of the program when delivered by nurses versus paraprofessional visitors. And a large portion of the families enrolled in the Denver trial were Latino. So it gives us a broad basis for understanding the degree to which findings replicate and apply to different segments of the US population, especially those in need. Next slide, please. Okay, thank you. So this slide shows those major outcomes where we have replicated effects in at least 2 of the 3 randomized trials. We see significant effects on women's prenatal health, especially prenatal tobacco use. And we see effects on hypertensive disorders of pregnancy. We see significant reductions in children's injuries revealed in the medical record. And I think it's particularly important that in our 2nd trial, we see a significant reduction in the number of days that children are hospitalized with injuries compared to the counterparts in the control group. We see corresponding effects, replicated effects on children's language and school readiness and school and achievement, cognitive performance that are limited to essentially those children born to mothers who have low, what we call low psychological resources, that has limited capacities to address or deal with the adversities in their lives, limited intellectual functioning, limited mental health functioning, and limited sense of mastery over their life circumstances. We see significant replicated effects on children's behavioral problems, depression, anxiety, substance use in early adolescence, reductions in maternal impairment due to their substance use. We see significant cross-trial effects on reducing short interpregnancy intervals, increases in maternal employment, and significant reduction in welfare and food stamp use. Next slide, please, Stephanie. In our Denver trial, we see that nurses produce effects that are roughly twice the size of those produced by paraprofessionals. And it's due to 2 things. One of them is that nurses, families open their door more for nurses. And even when you control for differences in dosage of the program received, nurses continue to produce greater effects than comparison families. And we think this is due to the clinical foundations of the program. Stephanie, if I could have the next slide, please. Rather than ask families directly about ACEs, we employ and have employed from the very beginning in this series of trials what we would call a life history assessment. This is a general introduction to create a context for mothers to reveal who they were living with, what it was like growing up. What were some critical events in their early life and development? It creates an opportunity for the nurse to reflect on mother's hopes and fears. And one young mother had been tortured as a child, and she said to her nurse, "I don't help me not do this to my own child." And this is it's in this context that is created for an exploration of these relationships early on in the program, that mothers feel safe, we think, in revealing those things that were most important to them growing up. Next slide, please, Stephanie. And I think it's important to realize that nurses are looking not only at early trauma, but they're also assessing mother's current personal health, her maternal role, where she stands in terms of her own life course, the relationships she has with family and friends, the physical and social environment that she's living in, and her current use of other health and human services. Next slide, please. I think that reflecting on life history early in the program is really critical in helping mothers explore their hopes, their fears, to understand the context of their mental health functioning, their substance use, their patterns of intimate partner violence, their caregiving beliefs, and to ground this in this historical context in a way that does not threaten women about revealing these things that have been going on in their lives. We started work on addressing intimate partner violence and did qualitative work with mothers. And mothers said to us, "Do not hit us over the head with these questions because we feel ashamed and about our having endured these kinds of situations. Treat us gently." And so that was a general lesson for us. If I can have the next slide, please. I guess that's it. So in any case, thank you very much. Oh, no, we have another slide. I guess this is generally, you'll see this slide is, we think it's a strengths-based way of our engaging families around this set of issues. Thank you.
Thank you, David. Okay, that concludes our presentations. I have a question from the audience, and feel free, for those of you in the audience, feel free to submit questions via chat to our panelists. And we have 15 minutes to have a great discussion. So the first question is, we heard earlier today from Dr. Minkoff about the need to develop systems and programs that address multiple risk factors, i.e. mental illness, substance abuse, domestic violence, child maltreatment. We then heard from the following on the panel discussion about the impacts of social issues, poverty, low income, unemployment, lack of quality education, inequalities, and how little attention we pay to these family impacts, and particularly how they relate to the risk factors. Shouldn't we do more research to better understand this intersection? And how can we integrate a total approach?
I'll weigh in on this. The answer is yes. I think that when I was listening to Hai and Steve and Eugen talk, I realized that we are at a point where we need to think systemically about how we might be able to address these issues in a more cohesive and hopefully more powerful way. And I also agree with a number of people who talked about the importance of primary care. I think that primary care can and should be a major link for bringing these systems together early in life. Usually, not always, but usually primary care, pregnant women, parents of young children trust primary care providers. And I say that with some qualification because we know that that's maybe especially among African-American mothers or people, there is some real warranted apprehension about those providers. But in general, there's systematic engagement and involvement. So I would start there.
Yeah, I would agree 100% with David. You heard a terrific kind of program that he has developed and is working. We don't have enough nurses in the world to take care of all the families that need to have that kind of intervention. One way to help solve that problem is to build a stronger capacity of all the other agencies and services that are available to people, so that those agencies have the same mentality or the same reflections or the same sense of what's important in development, and can begin to more carefully refer people to the kinds of services they need. You heard Jenna talk about the lack of trust. We have the lack of trust in Australia as well. We have to think in many of our countries about indigenous knowledge, because the indigenous people of Australia really don't trust white service deliverers. And so because there are practically no indigenous health service providers available for them. So that would be probably true also in some of our American Indian, Alaska Native populations as well. So families live and are surrounded by the circumstances of life. We can help a mom and her baby connect better, but they still live in poverty. They still are exposed to other kinds of external adversities that we can't fix. We can't make a poor family rich, but we can provide them with better relationship experiences that can help them build those strengths that David was talking about.
So hi, I and David, you know, I agree with that, but I often will say that if we had true livable wage in this country, we all had half the amount of work that we currently have. I do think there's policy that can change and should change how people are paid, what the economic situation is, that would vastly decrease the need for our work. I think, you know, the Engel Costello, you know, Smoky Mountain stuff and others have shown how much the environment and economics influences things like maltreatment, ACEs and whatnot.
Yep.
Okay, thank you all. We have another question. David, this is for you. How many states with NFP programs hire mental health consultants in the teams of nurse home visitors? And how can early prevention of ACEs be integrated with the duty of mental health consultants?
I'm not sure how many sites have hired their own mental health consultants, but I can tell you that there is a significant effort going on nationally to strengthen nurses' skills in addressing mental health issues in England, the program, every site in England is supported by a mental health consultant. There is a group there's a randomized cluster-based trial that's being conducted right now of an intervention focused on depression and anxiety in US NFP sites, designed to strengthen the very issues that this person who raised the question is getting at. So it's on our agenda. We've invested a lot of time in strengthening the clinical aspects of the program and addressing mental health issues, and we're testing it.
Okay, great. Thank you, David. I have one last question. I don't see any other questions in the chat box. So as far as early prevention work, where do you see the most pressing areas of need, or where do we need to move forward? We have many practitioners on the line and some early practitioners just getting started in the field. Where do you see things moving in the future and most pressing areas that we should be thinking about?
Jen, why don't you answer that?
Well, I
have some thoughts.
Okay, I will. I have a question. I feel weird answering it, but I will say that, over in the other session right now with integrated care, we have a lot of people focusing on primary care, but more importantly, or as importantly, they're really thinking about the connection to community and leveraging what our communities have to offer. And I think that's a great place for people to think about doing prevention work and how we can really build that intersection that Vincent Atchity was getting at the end. What do we have? Steve mentioned some on the policy, but what do we also have just in the community that we are not fully leveraging and working with and partnering with to help, around with those wraparound services and just the social determinants of health that we offer in our, our communities.
If I can also address this, one of the things that has struck me over the years is that when you ask the public which professionals are most trusted, the answer is consistently, has been for decades now, nurses.
Mhm.
And I appreciate Hai's comment that we don't have enough nurses. One of the things that I've observed is that we've been concerned about just, people have talked about the nursing shortage again for decades. I happen to believe that, first of all, nursing attracts people who want to serve. And because of the reputation that nurses have, and because they're able to address the full array of needs that families in pregnancy and the postpartum period and the early years of life have in a comprehensive way, that I think they're actually well positioned to address this issue. So I would like to see more emphasis placed on nursing education, identification of nurses early in life who find this kind of work worthwhile, motivating, and find a way of leveraging more of this deep drive to serve in a humane way into nursing, partly because there's such a good fit between nursing and the population's needs at this phase in development.
I mean, I agree. But we have to look at more carefully and deeply at the transitional stages of development, the systems that are impacting families. And for example, we need to pay early childhood preschool teachers a decent salary. I mean, give me a break. Pay them $25,000, $30,000 a year, and that's now close to poverty, particularly if they have a family of four. And yet they have such an enormous responsibility for overseeing sometimes 20 developing children who at that age are still in a critical phase of neurobiological development and brain development, and their regulatory system, on and on and on and on. And we know that ACEs experienced 0 to 5 or even prenatally have a much higher probability of leading to life course adversities. So that early childhood, yeah, nurses, teachers, parents need to be more, and then as Steve said, you know, if we cut poverty from 35% to 15%, we would see a dramatic increase in all kinds of things that would be more positive in child development. So it's a complicated answer to a complicated, complex system.
The only thing I would add in the kind of armamentarium we're talking about is I don't think we do a really good job of supporting sort of the natural community caregivers who are there, that everybody knows about, that have access to information, to people, and that really trying to think about, you know, sort of the barefoot, you know, model of people in the community and supporting them and bringing them together as leaders to support the you know, their colleagues and friends, I think has shown to have a good impact. And we don't do enough of that. We don't do enough of really helping them be as good as they can be and as effective as they can be. I know you're doing some of that actually, Jen, in the Valley, but I think much more of that is really what's needed as well.
So I agree with what Steve just said, and I just want to point out that in Australia, we have 13 sites working in Aboriginal communities in Australia. And in all of those sites, part of the condition, one of the requests by the Australian government was that we create a special role for Indigenous people to work alongside nurses. And I think that's really done two things. One of them is it created an opportunity for employment, but also creates safety on the part of the families, cultural safety. And we have the same kind of relationship going on in Bulgaria, where we are serving Roma families, and they have the same kind of, if you want, Indigenous or local person who pairs up with nurses. So I think that's in some, maybe especially where populations are really feeling the history of deprivation, and that's worthwhile. I also think what I've seen over and over again is that many mothers who've been through NFP want very deeply to give back to their communities, and they have gone on to become nurses or other service providers in their community because of that, if you want, instigation, or that of their own, because they've been cared for, they want to give back. It gives me hope, and it doesn't always take the form of becoming a nurse, but it gives this drive to help improve my family and my community.
David, we'll end on that hopeful remark. Thank you all for the great presentations today. That concludes our session. It'll give you a little bit of time to make your way hopefully to the next afternoon sessions that start right at 2. We have mental health and technology, as well as a session on health equity. And I believe you should have received both calendar invites, so you can just click on whichever one you'd like to go to or go back and forth between them. And thanks again for attending today.